Okay, hi guys.
Hi.
Um,
Hello.
Welcome to episode 3 of Girls Gone Verbal, a social work podcast. We are in a new location today. We are on Microsoft Teams, but we're hoping to make this still an amazing discussion, even though we are in different locations.
Mm-hmm.
So today we have a guest with us. Reagan, would you like to introduce yourself?
Sure. Hello. So my name is Regan. I am in the UCF MSU part-time program working on my MSW, and I also work at Orlando Health. I am an educator with corporate care management, um, with the REACH program, which is outpatient social workers. Very, very excited to be here with you guys.
Thanks for coming.
Thank
Thank you for being
you.
here.
So we're excited to hear about your experiences and to talk about ethical decision making, our growth in that area as social workers and interns. And we're also excited to talk about boundaries and countertransference and transference. So we're going to kind of move the flow in that direction. Reagan introduced herself. If we have repeat viewers, you guys may already know the three of us, but just to introduce ourselves to any other viewers, my name is Virginia Pinzon. I'm an intern and MSW student, and I'm interning at the REACH department at Orlando Health. Who would like
My
to go
name is
next?
Sheridan. My name is Sheridan Mutu. I am a mitigation specialist intern at the Office of the Public Defender in the Ninth Judicial Circuit.
Carolyn Morel. I am an intern at UCF Restores. I'm also the president of Phi Alpha, which is our honor society here at UCF. I'm in the MSW program, and I'll be doing my clinical at the Veterans Affairs Office in BHIP coming next semester.
Yippee!
Congratulations. That's amazing.
Thank you, thank you, thank you. I'm very excited.
And Carolyn, actually, you mentioned you're the Phi Alpha president. This episode is sponsored by Phi Alpha, so feel free to share a few words if you would like to.
Well, thank you, the amazing vice president of Phi Alpha Social Work Honor
Please,
Society,
no, no.
New Pi chapter. We would just like to announce that we are in planning stages for next year. We really want everyone to join and participate. We have an event actually this Friday. It's for NASW, which is the National Association of Social Workers. They're having a little mixer. You can get free drink tickets, you can get swag.
Ooh.
Um, that's published on Night Connect for anyone to view, as well as we just sent out an interest form. So we want to see, what would you come to? Are we wasting our time? Are we doing something valuable? So please, if you receive the interest form, fill it out, and we want to hear from you.
Thank you, Carolyn. So let's get started on our riveting discussion. Before we talk about the process of making ethical decisions, it's probably a good idea to begin understanding the values that we bring into the profession.
Mhm.
So, what stands out to you about the values of the social work profession? If you could pick one value that really resonates with you, what would it be?
I said I thought of two that really resonate with me. One is connection, creating meaningful relationships. I like to help people feel seen and supported. This would be a personal value as well as a social work value, as well as service. So showing up for others. I don't know if I shared this with you all, but my family were missionaries overseas when I was a kid, and my mom worked at the school I went to, and I just found out like this year that she worked for free. She didn't
Oh,
get
wow.
paid. She was like
Wow.
the bookkeeper, then she was like the vice principal, she was the principal, worked for years, wasn't making a salary because of her dedication to service. And it really made, so it's like part of my values of how important it is to give back where we can. And I love
Yeah.
that about social work.
What stands out to me about social work is dignity and worth of the person. That one really resonates with me. I can't really put my finger on why, but I think also similar to Carolyn, it's kind of the way that I was raised, like it's deep-seated in me. I really appreciate that social workers put everybody on the same playing field. Not everybody isn't already on the same playing field. We've talked a little bit about oppression and power dynamics, but when a client is talking with a competent social worker, they do the best they can to recognize, you know, what are they called? Hidden biases, and to work around the system that is causing some kind of issue in a person's life. And I think that that's important to me. That's just what I appreciate about social work and what I think about a lot when I work with a client.
I like what both of you guys have said. I was also going to say dignity and worth of the person. That one is very, very important to me. And it's also part of how I was raised. I think that for a lot of social workers, a lot of these values are kind of innate within us already. And that might be part of the drive that pushes us to do social work in the first place. But I would say dignity and worth of the person, as well as principles of social justice and like upholding diversity, equity, and inclusion to the extent that, we can now in our agencies, that is also very, very important to me.
Yeah, I feel like it's difficult because you guys are everything you say, I'm always like, yes, yes, yes. But I feel like that's kind of the community of social work is like we all understand where each other is coming from and kind of feel similarly about things. So the dignity and worth of a person, I feel like, is always, like you said, innate, it's in us. We always feel that way. But I think for me specifically, what I really, really appreciate is the value of like education of ourselves, of like continuing to keep ourselves informed, reading up, doing research, because at the end of the day, if we know enough about what's going on and we keep ourselves educated, I feel like we're able to provide better service to our clients and patients.
Yeah.
And it's also like a personal value of mine. I love education. I'm a current educator. I just like, I love it. I think it's amazing to keep ourselves knowledgeable. And I really appreciate that social work also sees that as important. And, you know,
Yeah,
so.
it's written in our code of ethics, like incompetence, that little blurb about making sure that when you provide service to a client, you know what's going on and you know what you're doing. And when you don't, to like draw a line there because it can harm a client if you don't know what's up. So you always got to keep up.
Yeah.
For lack of a better word. So it sounds like we align on, like Regan and Sheridan mentioned, we align on a lot of our values in social work. So that's easy to discuss when we're all agreeing. But the issues come along when our personal values and our professional responsibilities clash a little bit, or they don't perfectly match. Where do you guys see congruence or a possible dissonance between your values and those of the profession? Or the way I thought of this question too was more about agency policies.
In what way?
Like, where do our values clash with your professional obligation as an intern or a professional in your agency? That's the way I interpreted this question. I don't know how you guys feel.
I think that's one way to interpret the question for sure. I know personally, I actually align pretty well with the policies at my agency at the Public Defender's Office. In the last episode, we talked about how there's also like a legal aspect of that kind of work that I do, right? So even though you may have personal beliefs or values that might be in conflict with what you should be doing for your client, they still have the right to representation, to be represented and advocated for regardless, right? And I think that that's also the same for like any agency that you work at, right? So
Yeah.
I would say I interpreted this more as my own personal beliefs or maybe my own biases against certain lifestyle choices or decisions that a person makes that I just maybe I was raised in a way that like this decision is just not what I would do, right? Or and you know, to be vulnerable, that is something that I do struggle with sometimes still. Less with my clients and more like in my personal life, right? So I think
Yeah.
social work values have really in influenced me to be more open-minded, to be more understanding of the cultural and social and environmental context behind people's decisions because you never know what how those things might influence a person's decision. Maybe it's not the way that I was raised, like my, you know, within my culture and in my upbringing, being in social work and learning these values and applying these values to my clients has also helped me practice them in my own personal life as well.
That's cool.
Practicing them in your personal life too, it just makes it that much easier to like turn it on when you're at work.
Exactly.
And I think you learn about yourself too, not just like critically thinking about how other people make their decisions and where that comes from. You think about where my reaction comes from. So
Yeah.
the way I interpreted this question was a little different, like we mentioned. I thought more about like professional obligation versus personal values. So I know that sometimes my personal belief might differ from what something like a policy at my agency is obligating us to do. So the one that comes to mind for me is like resource scarcity. Sometimes we're able to give a client a phone if they have no way to contact anybody for like follow-up medical appointments. Like we give them a phone with minutes on it that they can text people to make sure they get to their appointment or make sure they get reminders or contact their provider. But we don't have an unlimited amount. And as many patients that we have that don't have a phone themselves, sometimes there are still ways that we can get in touch with them, like through calling an emergency contact. Maybe they're there or they'll pass along the message and borrow a friend's phone. But we, so in that way, resource scarcity comes to mind for me a little bit like an ethical dilemma, because as much as I personally would love to just be like, oh, here, you don't have a phone, here's a phone, we can't do that. So um, sometimes that's a little bit difficult for me to grapple with, but there's not really much we can do about it. So then we come into like we have a framework for how we decide to give a person a phone. And we kind of go through that decision-making process and staff the case with a supervisor or another social worker or lead, and they help us work through that decision-making framework to determine if we can provide one of the few phones that we do have to offer.
Mine was really similar. I was thinking like fairness versus systematic limitations, which is similar to what you said. Like systems are inherently unequal and under-resourced, but that might be against our values where we want things to be fair and we want people to have access.
Yeah, I think Sheridan and I kind of thought about it similarly, I guess you could say. And as I was hearing you talk, I'm like, that's exactly how I feel. Because while I do work at Orlando Health as an employee, I'm also doing my internship with a different department at Orlando Health, like generalist internship. And the policies are different. So like Virginia's familiar with the REACH policies, right? So she's familiar with like what we do and the phone, concern. But with inpatient, it's a bit different. And I when you were talking about how patients, one of the values is like patient's ability to make their own choices. And like if they don't want the service, they don't, they don't need to do the service because they can choose for themselves, which they should be able to. But like with my internship, so I'm doing discharge planning at the hospital at Orlando Health, so a little bit different. There's a lot of patients that, like you said, cultural, like kind of trying to understand the different cultural limitations sometimes, or beliefs that are different than ones you might be used to, or different, reasonings for things. So one of the things that I've seen as like maybe like an incongruence is like when they need a certain level of care. Like let's say we have an elderly patient that, they cannot go home by themselves. They're sick, they can't walk by themselves, but they still have the ability to say, I don't want to go to that facility. You're going to send me home alone.
Yeah.
And at the end of the day, we have to send them home alone with home health care. But it's like, as a social worker, I don't want to send you home knowing that you're, going home with just home health care and some family support. Like I want you to go to a facility, even though you can choose not to. So it's like one that's like, it's a policy throughout everywhere with healthcare. Like it's not just like my agency, it's every agency that works with patients discharging home, or discharging anywhere. So, and there's cultural limitations that too. Sometimes, the family really wants to take care of them and they can, make that decision. Like specifically, have a lot of patients that I work with the families that are like from Haiti or Haitian Creole speaking. And a lot of them are really big on family, taking care of family, and like upholding that and sticking to that. And so I've had patients recently where, they're declining hospice, they're declining, certain services because that's just not something that they do, but that it would be a comfort measure for the patient. So
It's like you guys both you and the patient want dignity for the patient, but their version of dignity is different from what we would consider dignity. Is like, we think
exactly
working at the hospital is like the best medical care, the most comfort that can be provided. But for them, it's the ability to stay home and be with their family or take care of themselves if that's what they want to do. So,
exactly. So you send them home with home health care, make sure they're covered, make sure they have care, but it's not, it's what they want. It's what you do.
Yeah, that's a really good example of an ethical dilemma that you've observed at I would say your agency, but that's where you work too, but at your internship. Do you guys have any other specific examples? If not, I can go. I've got one off the cuff.
Of ethical dilemmas?
Yeah, I thought of this beforehand.
Okay, I want to hear yours.
So, one ethical dilemma, I guess, that I remember specifically encountering this a lot when I first started, and I think it's a common thing for interns, is that when we call a patient to see if they need any like basic resources or primary care access, sometimes you speak with a family member first, and the family member expresses that the entire family is really in need of a lot of different resources. And as social workers, and personally, I just want to help them. I want to help anybody I'm speaking to. But it can turn into an ethical dilemma when the case gets so complex and there are so many people involved that it's not patient focused anymore. And it is out of my scope of knowledge. So then it kind of overlaps with it clashes with our ethical value of competence, like Regan mentioned earlier, to make sure that you are up to par on what you need to know within your role. Sometimes people need things that there's no fudging. I don't know how to help. And if I try to help, it just is worse for the patient. So in those instances, I'm not saying like specifically because like for patient privacy concerns, but that happened a lot when I first started at the internship, and trying to navigate those conversations and refer them out to agencies that could help them long term or that could help their friend or their sister so that the case would stay patient focused and stay aligned with what I know how to help with. That's how we would address that.
I think that's common in medical social work in general too. Like, I don't think it's just our interns that feel that way. I think it's across the board because medical social work really is patient focused. Like the patient is my patient, especially with like women and children or like the children
Yeah.
population in general, where you have a mom, the child who's your patient, and then you have 3 kids that are not your patient and you don't have access to their medical records and you cannot look at their medical records because they're not your patient. And
Mm.
they ask you, oh, you got my one child insurance case manager, oh, you got my one child in with this doctor and you did this and this and this, but at the end of the day you cannot feasibly help these other 3 children because you cannot access their medical records. And it sucks that it's that way,
Mhm.
but it's like when the family gets involved, it's like there's it's like you said, out of your scope.
It's
But it sucks.
difficult. Yeah, it's hard for the social worker and for the family. Oh, we have another guest on the
Sorry.
show.
My
No,
cat
no
decided to
apologies.
say hello.
Oh,
This
I
is my
love her.
cat.
Is she gonna introduce
His legal
herself?
name?
Oh.
Yes, his legal name is Bartleby, but we call him Bean.
Oh,
Our little
my
baby.
gosh.
He's a really
I
good
love
cat. He lets you
him.
hold him and do whatever you want with him. He's amazing. But this is Bean.
Hi, Bean. Welcome to the
Hello.
podcast,
I
Bean.
know.
Yeah, hi.
Oh, I love it.
Thank you. Thank you for that introduction.
So ethical dilemmas that happened at our office. One of them that happens a lot is people calling for somebody else. So they'll be like, oh, my husband, he really needs therapy. Here, let me give you the phone and you could talk to him. But we have a policy like people have to call and ask, and they have to call to ask from their phone. Or like they work at a fire department and the peer support person will call and be like, oh, I got this person here. They really need to come to your therapy. Like, I'm going to put them on the phone. Be like, no, like, we'll give you our number and then they can call. Because, like, that, they're, we don't know if they're being under duress. Like, they're being told to do it. Somebody's listening to their personal information. They're going to do it, like, out of compliance because they were made to. We'll say, thank you so much for calling, but you're going to have to give them the information and we're going to hang up the phone and they're going to call and they're going to ask. And that's like straight across. It happens a lot. As well as like brokering happens and we don't allow that. So like, let's say, there's a law enforcement officer and there's like an accident work and he gets shot during like a practice, right? And now he's like having PTSD from that. So then the broker and HR person calls us and they're trying to arrange treatment for that patient. But then like some time goes on and then the HR person calls. They're like, oh, did they book that treatment? Are they coming to you? Are they a patient? We cannot say that they're a patient. And then that person tells the HR person, oh, I'm going to fill out a release form. They never fill out the release form. Then the HR person calls again. Oh, they said they're going to fill out this release form. I'm going to get information. Oh, sorry, they haven't filled it out. I'm assuming they haven't filled it out because they don't want that HR person to get information, but they told them they were going to do it. So there's like a lot of that too, like a lot of different people interested in whether or not they're getting, because they want to be released. So another thing is like fit for duty, because these are law enforcement, firefighters. If they're on leave, they're invested and their department's vested for them to get like certified that they're fit to go back to work. Especially if they had like some sort of like mental health crisis because of something that happened. Like they had a really bad call, they saw like a pediatric death. Now they're on leave for that. They have to get a fit for duty to show that they can come back on. When they're on that leave of duty, they're getting paid less because they're not getting hazard pay. So then maybe they're motivated to get this fit for duty. We don't do those. We don't say that they're fit to come back to work. That's like a whole separate thing.
Yeah. Yeah.
I got some character references. People have asked therapists to give them character references. We cannot do that.
I was going to say that sounds like an ethical dilemma if I ever heard one.
Yeah, to say how great somebody is.
Yeah. Yeah, wow. But that must be hard to like have a client asking for those things that, I mean, we said it a million times, like we just want to help people. So it must be hard to decline them that. Even if it's something you don't normally do or ever do, it's like, I'm really sorry, I can't help you with that. It kind of feels like, I'm sorry, I can't help you get your pay, you know? So that's hard. That's
Yeah,
hard for
yeah,
us
yeah.
to
We
do.
want to support people, but unfortunately or fortunately, like there's parameters around our role that maybe other people, like clients, aren't thinking about when they're requesting things. And I think that's a lot of these ethical dilemmas we're talking about now is
Mhm.
people requesting services that are outside of like what we can ethically do, outside of our scope, outside of like what our role should be in
Mhm.
their care.
Have you learned anything about yourself, Carolyn, as you have these conversations with patients or
Um,
clients?
my learning thing that I've been working on is like, this is my personal life and my work life, but like strong opinions versus client autonomy, which is what Reagan was talking about. Like, what is best for them versus respecting patient choices. But also like people in general. I think I learned a lot about that when we watched the videos on like motivational interviewing and like
Yeah.
recognizing when we feel that patient feel those feelings about like what is our opinion versus like what is their autonomy.
Right. Yeah, like emotional interviewing, the lessons we had were some of the strategies is to like really put a lot of emphasis on autonomy. It kind of gives the power back to the client. It's like one of the principles.
Yeah. And like iterating that to them, like when they
Reminding them,
that they yeah,
you know?
even like people like if people say if I talk even if I talk to people in personal life about like making a change, like my brother's daughter, my niece is 15 and she gets stomach aches all the time. And I was like, if you get stomach aches all the time, like maybe there's like a food you're sensitive to, maybe it's something you're eating. And she's like, I'm not ready to make a change in that area right now. And I'm like, okay, like,
Okay,
yeah,
you
you
don't have
definitely
to.
have that, like, right? Like you're your own person. Like if you don't want to make a change, like we can change the topic.
Mhm.
Like,
Yeah.
I think that comes up in therapy a lot, like as the therapist. So prior to this role, I was a substance use therapist
mm,
with clients who were going through DCF cases, their children taken away, or they were court ordered and working with their probation officers. And something I noticed during my therapy stint of work is that same thing too, not medical social work and autonomy, but also in the therapeutic setting of like you can't tell them what to do. Like something's hurting them.
Yeah.
Like you're watching
Yeah.
it hurt them. You know that what like their actions of themselves or their actions towards another are like obviously not like harm of like, you know, extreme harm, but it's like those steps are not good for you and you can't sit there and be like, "Hey girl, like you're messing up. Like you can't do that." It's like no, you have to walk them through these different
Mhm.
avenues to show them and
Yeah.
it's I think that's difficult too as someone in social work and as a social worker is recognizing like your job is to help lead them to something that they
Mhm.
are looking for and not putting yourself into
Yeah.
that relationship, your opinion and your biases and everything.
I have a very similar experience in my internship because a lot of clients, we refer them out to different programs, substance treatment facilities, and usually it's the attorney that will let us know if this is like their plan for alternative sentencing to get them out of jail and moved into a facility. And I've had clients tell me, no, I don't want to go. Like they'd rather be in jail than go through a treatment program. And it's like you you want so badly for them to go to that program. It's like one, you'll get out of jail. Like you will be out of jail. But like it's like you can lead them there, but it's up to them ultimately. And so I also do remind them of their autonomy and the fact that like you can refuse to do this, but then, our bargaining chips to get you out of here are like very, very limited, right? Um, so I guess that's one of the ethical dilemmas that I face is like, the upholding the client's self-determination, but also wanting what is like best for them and safest for them. So that's difficult. And then I thought of something else while you guys were talking. Another ethical dilemma that I face in my internship is that a lot of clients will ask me for legal advice or information when I go see them at the
Oh yeah, I
jail.
can imagine.
Yeah, so they think that I am, in on the details of what's happening in their case, and I'm absolutely not. I have no idea. So I literally just have to tell them, I'm like, I am not an attorney. I have no idea. You have to talk to your attorney about this. But almost every client that I see, they're asking for information about their case and what's going on. And understandably, like the public defender's office is incredibly busy. So like I've seen clients that are like, I still haven't even met with my attorney yet, so I have no idea what's going on. So I can understand them asking me for information, but I can't provide them with any. Even if I know something that they're asking me, I will not give them any legal advice or information because that's not my field and I can't enter that realm.
Sounds like the kind of theme that I'm seeing here is when you have an ethical dilemma in front of you, one of the ways to manage it is to like fully inform the client, like lay everything on the table, all of their options, what you know, what you don't, so that you guys are kind of tackling it together. And then also we talked a little bit about in terms of the competence value, ethical value, whatever you want to call it, is like referring people out, making sure that they're working with somebody who does understand or can help them. And then Carolyn, you kind of mentioned, I think you mentioned managing your own personal feelings. We all did. Now that I say it out loud, I'm like, we all talked about managing our own values and our own ideas of how a person should be treated with dignity versus how the patient wants to be treated with dignity, and reminding them about their autonomy. So I know one thing I've learned about myself as an ethical decision maker is that I'm getting better at setting boundaries with clients. And I think because I'm getting better at setting boundaries and staying within my limit, I'm also getting better at advocating for patients in the scope of my role. Like I'm understanding my role as a, short-term case management, social work intern. And I think a lot of that has to do with how we've talked about the benefits of supervision in the past, but being able to staff cases with social workers who have been through scenarios like these a lot. So that's helpful for me too. And I think has helped me learn how to set more boundaries. Obviously, still a work in progress. We always have to continue growing, but I noticed myself getting better at that. But one ethical topic that we can explore today includes managing boundaries, jumping off of that, and countertransference. So transference, if you didn't know, is when a client projects their feelings about someone else onto the social worker or therapist. So, and countertransference is when we react to a client based on their own past or based on the feelings that they put on us, if that makes sense. Has this feeling come up for any of you guys in your placement or at your job? And how did you handle those feelings?
It's a hard one because I think it's hard to it takes a lot of self-reflection, I think, to be able to look at something you're going through and be like, "Oh, that's countertransference." Like, okay, I'm seeing that. Like, you really have to know yourself really well, and I think that's a good part of like also like the social work values is like continually looking and reflecting and like understanding yourself when you walk into stuff. So I know, like, for me, I work in the medical field. My internship's in the medical field, and in my past, my grandmother passed away a couple years ago. And when we got her death certificate, it said heart disease, but we never even knew she was sick. Like, she never told anybody she was
Wow.
sick. The whole family, even her kids, were like, "Excuse me, like, what are you talking about? We thought she was so healthy."
Mhm.
And I harbored a lot of, like, I wouldn't call it like anger, but, like, confusion, right? Because didn't know
Yeah.
she's, sick. And then a couple years later, I get into medical social work. And Virginia, I'm sure you've had a lot of patients similar to this. I have a lot of patients that have heart failure that just simply are not following their diet. My grandma didn't follow a diet. Now that I know she had heart disease and heart failure, I'm like, woman, you were eating soup all the time. You can't have liquid. You were drinking all this water per day, and you can't have water like that. So I think in the beginning, when before I had like that reflection moment, I'm like meeting these patients and I'm leaving the room and I'm like, why are they just not doing it? Like, why are they just
Mhm.
not doing it? Like, they need to be following the diet. They need to be weighing themselves. And then after a couple weeks, I was like, huh, yeah, so can't save them. It's not my grandmother. I'm not going to save them. It's their choice again. Patient autonomy, like, they can do that. But that was like one time. Oh, his food's going up. He's gonna run. Um, but that was one, I guess you could say, experience. Not that I like said something to the patient. I have a couple times been like, hey, like, you probably should be doing that. It's best for you. But definitely reflected and realized that that's
Mm.
probably what was happening.
Wow, thank you.
Regan, I think it's really, I'm sorry for your loss, by the way. I think it's great that you were able to recognize that after working with patients that shared experiences with something that was so close to your heart. Um, I think that it would be hard to recognize that if it was so related to something that meant a lot to me. And that's something that I see in my placement too, or just as interns in general. It can be when you start to work in social work, you notice some connections to clients, and then at the end of the day, you're kind of feeling a little bit bummed out, or maybe you're thinking about them the next day, and that's when I start to feel like, oh, maybe this is not healthy. You know what I mean? So it's hard to recognize that though. The experience that I have with countertransference, or I guess transference and countertransference, is that when I have a client who, and this recently happened, who doesn't really trust social workers, with the history of the social work profession, like, not the best reputation for a long time. We were like child stealers. We were out to get people, to make them do things that they didn't want to do. I think that's changed a lot. We're starting to move in the right direction. But there are still a lot of people who have had negative experiences with social workers, especially people who are oppressed by the system that they're living in. When a client brings that up to me, I feel sometimes that could be an example of transference, because for me, I'm just starting a conversation with them. I've never met them before, but they bring these feelings to our interaction based on the experiences they've had in the past. And that is difficult for me because I feel like maybe some sort of countertransference, like, I know in those situations, I have a tendency to react emotionally because I do want to help them and I'm not the person that hurt them in the past. But um, a client has every right to make the decisions they make. And if they haven't had good experiences with social workers, or they don't want counseling, they haven't had good experience with mental health workers, then who am I to tell them to conform to the mold and get this help and go to that follow-up and make an appointment with counseling? That's not my job. When I have somebody who has these feelings and I catch myself taking it a little personally, or like feeling like I might react emotionally, I try to center myself, and I will remind them, kind of how we talked before about autonomy. Okay, yeah, I understand that you didn't have a good experience in the past. I'm sorry about that. You don't have to do anything that you don't want to do today. We don't have to even you don't have to answer all of the questions. You can skip ones you don't want to answer. You don't even have to get these resources. This is all about what you want. You're the expert of your life. And that's how I've handled it in the recent time that it's occurred. And I think that kind of hit close to home. I feel like when I spun it that way with the client, we were able to continue the conversation in a little bit of a more productive light. Do you guys have anything else to add to that?
Yeah, I've had very similar experiences before with a lot of my clients now. They've received services from social workers before that they feel maybe it wasn't helpful, or maybe it wasn't comprehensive enough, or there wasn't follow-up. And so they're just generally very distrusting of me. As soon as I walk in and sit down with them, it's like, what am I signing all these forms for? What are you going to do with this information? Like, it's already a very distrusting attitude, right? And for me, it brings up a little bit of frustration in me, because it's like, I'm here to help you. Like, I want to help you. I'm here. I'm helping you sign these forms because this is what is going to help you get out of jail, right? And into a situation that, is better for you. And so I've experienced that frustration as well. And I think besides that, I've also met a lot of clients who don't really hold themselves accountable. They put a lot of blame onto other people or their circumstances, which of course circumstances have have a really big role to play a lot of the time. But I've met clients that just maybe they committed the crime and they refuse to acknowledge that they committed the crime. It's like everybody else's fault but theirs, right? So that, for me, I know that has been a point of countertransference for me, is because I have experienced and dealt with people in my life that don't like to be held accountable for their actions, right? So that brings up a lot of frustration for me. And it's not my job to I honestly, I don't care whether or not you did it. I don't care. At the end of the day, I'm still there to provide you with the services that I'm there to help you with, right? But then I also come across clients that because they're so distrusting of these different systems that, I'm here to help them and I'm here to try advocate for them as much as I can. But it's for example, I had a client last week who has lost a significant amount of weight while being in jail. He's almost he's emaciated at this point. He hasn't been eating very much. He when he first was brought into the jail, he went to medical and told them, I have Ensures daily when I'm out of here. I need to have my Ensures and high protein diet because I lose weight very quickly. And so they put him on a high calorie diet. They don't have Ensures at the jail, so they weren't giving him Ensures, or that's what he told me. So they put him on a high calorie diet, but he's not eating. So every time I go see him, I'm like, okay, have you went back to medical? Did you talk to them? I understand the food is not what you're wanting, but it's he doesn't want to be underweight.
Yeah.
He wants to eat, but he's not taking the steps that are necessary for him to get better and get healthy again. It's no, I don't want to go see medical because they don't care about me. I don't want to eat this food because it's not good. So it's I can keep seeing you, I can keep advocating for you as much as I can, but at a certain point you have to also,
Yeah.
you have to want to help yourself. So bring all this back to countertransference is I've experienced people like that in my own life, and I think that's a sore spot for me, is when you keep asking for help, but you're not taking the steps necessary to also get that help for yourself. So when those feelings come up with me, I just try to I try to just ground myself and remember like there's only so much I can do. Like I'm not a superhero. We are social workers are not superheroes. We are just there to, advocate for them on the level that we can, right? And then if the client doesn't want to, if they don't want to receive the resources, then that's
Yeah.
that's it. That's all we can do.
Yeah. It sounds like you've witnessed countertransference at your agency and you have experienced it. How do you guys manage any sort of attachment to a client? Like if you leave your placement or your job and you have those feelings come up outside, how do you deal with it?
I would say for me, as we're coming up with these like the countertransference conversation and the like attachment, I think it really helps me that the population I work with is so different for me that I never experienced that feeling. Like they're men,
Wow.
they're firefighters, like let's say their parents are talking about like, oh, well, I saw this 2-year-old drowned and I have a 2-year-old. Like they're all of the experiences that they're having I've never experienced them. I can't relate at all. So it's like it doesn't, maybe that's like a great thing that's happening that I hadn't even considered as like an angle.
No, I think that's a good point. I don't feel it a lot when I work with clients, but the past 2 weeks I have had like an experience with that, and I can't say that I've witnessed it too much at my agency, but when I do try to manage those feelings, I think, like I mentioned before, what was helpful for me was to staff the case and to talk about it with a supervisor. So like I talked with Narita about it, and that was helpful. It kind of helps you to step outside of the box that the transference and countertransference kind of puts you in when you talk about it with somebody else, and to look at it from almost an outsider perspective and then go into the next call with a fresh start and like being fully aware of what you're feeling and how it can affect the client if you don't learn how to compartmentalize it.
I think like the taboo topic too is self-care. Like we always like say, oh, self-care, self-care. Like everyone kind of, it's like the thing nowadays. But I genuinely think that in those moments and the moments where you're feeling attached, it's good to remember like what parts of self-care you need to do. So like on the phone with somebody that you really feel that emotion with or attachment to or whatever it is, like stepping outside and taking a walk, like removing yourself from the setting to like
Yeah.
regroup yourself, and then you can come back in and make sure you're like at that 10 out of 10 to provide, the greatest service you can to the next patient or client. So I think self-care is like a good answer, but I know everyone's like, self-care.
I feel like yours is different. It's more like, because I agree with that a lot. Like for my work, when in my office and I'm like so focused on something, to just stop doing that and just like take a walk, look at some trees, touch grass, like recalibrate.
So I think we have had a really good discussion about all of these topics. So we started out by discussing how we feel about the social work profession, what values we're drawn to. Then we talked a little bit about how our values can overlap as social workers, but may not align at the policy or professional level. Or maybe we run into some concerns about conflicting values in the field. We talked about how we manage that and how we've grown as social workers as well. And we've also talked about boundaries, countertransference, how we handle those situations. So that's all I have for you guys today. I feel like we did a really good scope around those topics. All right. Well, thank you for listening to episode 3 of Girls Gone Verbal, a social work podcast. And thank you, Regan, for joining us today. We really appreciated your insight and your experience. Thanks for coming.
Thank you for having me. I loved it. So fun. Social work.
Woo!
Social work.
Oh, social work, go!